Welcome to Top Med Talk. The Society of Cardiovascular Anesthesiologists annual general meeting is coming soon. Check out scahq.org now. More details at the end of the podcast.
Top Med Talk.
This next session is one that I'm very near and dear to because I get the privilege of introducing some of my colleagues who I've had a chance to really work with and firsthand see develop and stand up at Perioperative Diabetic Clinic. And we're really fortunate to have Kathryn Kreider, an advanced practice provider, to really share with us that perspective through the lens of an advanced practice provider to this very important service. And I also am very happy to be able to introduce Dr. Tracy Setji, who leads that program as the medical director. So I'm going to welcome our moderator, Owen, to kind of take over and really manage the session. It's my privilege to welcome everybody back to EBPOM Chicago. Owen?
Thank you very much, Saul. Welcome back to Dingle. We're going to be discussing a lot of practicalities around managing perioperative diabetes and in particular managing a preoperative diabetic optimization session. So first of all, I'm going to introduce one of Saul's colleagues in Duke, Professor Kathryn Kreider. Do you want to tell us a little bit about yourself first?
Absolutely. Thanks so much for having me. My name is Kathryn Kreider. I'm an associate clinical professor at Duke University School of Nursing, where I am the lead faculty for the diabetes and endocrinology specialty there. And it's actually the first specialty training program of its kind in the United States. So we're very proud of it. It does have a large focus on diabetes management. And then with regards to this presentation today, I'm one of the nurse practitioners that sees patients in our preoperative diabetes optimization clinic. So it's been a privilege to be a part of that, and we look forward to sharing our experiences with you today.
Great to see you again, Kathryn. Can you tell me from a staffing point of view on the clinic itself, is it a true cohorted clinic or is it more of a virtual clinic? And how does your day work in terms of how much time do you spend dealing and how much time do the physician assistants spend dealing with the perioperative group?
One of the beauties of the way that we set this up is that we used our current infrastructures and our current staff. So from the endocrine side, we didn't need to hire anyone else to help see these patients. We were able to add new patient slots to providers that were interested and willing to see this population. And so we have about 5 advanced practice providers, which are nurse practitioners and PAs, physician's assistants. And we have several physicians that also see these patients. And so they were able to open up the slots, and then we each have several of these slots available each week to see patients in clinic. And then we, especially since COVID, we've been using a combination of in-person and telemedicine visits as well in order to see them more expeditiously. So the staffing actually has been fairly easy on the endocrinology and diabetes side. Thankfully, that's gone very well. So that's been a real benefit to the program.
Excellent, thanks. And is there someone who coordinates all this, or is this, again, as you say, automated and then built to Duke infrastructure?
When the program first started, we had several meetings about what the goals were for these perioperative patients, about how the communication structures would work back to the surgical teams. We discussed, sort of a consensus about how to sort of rapidly optimize patients. And of course, that's individualized to various patients. But we had several meetings up front. And then since then, it's actually gone really well. And we haven't had to circle back too often, just only when needed to talk about processes. But in general, it's gone very well and smoothly.
And then the interface from the inpatient to the outpatient, because I understand you largely work in the outpatient setting. So both pre and then post-operatively, how does that integrate?
Right. So we will see patients as soon as the referral is placed, and we're able to see them, as quickly as we can, depending on when their surgery is scheduled. And then we will communicate with the surgical team when they are ready for surgery from our perspective, which is, having their glucoses between 80 to 180 really is where we're looking at Duke. And then once they are admitted, they will typically see the inpatient endocrine team. And then they will coordinate an outpatient follow-up appointment with us afterwards if needed. If they're doing well and their medications haven't been dramatically changed, they may end up going back to their primary care doctor, but we ensure that they do have a follow-up appointment specific to their diabetes management.
I'm just going to bring in Professor Tracy Setchi now, who I know has been integral in the development of this program for some years. So great to see you, Tracy.
Thank you. Thank you for having me.
What was it like before this program was set up? And maybe, 10 years ago, what was a typical patient faced 10 years ago when he was coming through the services at Duke?
That's a really good question. And I think that would have been a lot of inconsistencies previously. So the endocrine team would often get involved in these patients because they came to surgery and their sugar was 400 and their surgery got canceled, or it was an urgent surgery. So they went ahead with it and tried to do the best they could with IV insulin to get the sugars down. But it was really that kind of frequent occurrence that made us want to capture patients further upstream, identify those that are going to be at higher risk for having hyperglycemia, and try to prevent some of that hyperglycemia, as well as prevent cancellations and prevent outcomes that could potentially be mediated with better glycemic control. So probably about 2016, 2017 is when we started having the conversations about trying to identify patients with their A1C as folks that would benefit from glycemic control program. And when we first started looking at this, we found some stakeholders within our institution, initially the spine surgeons and then the orthopedic team. And we worked closely with them to kind of work out the bugs of the system, establish what our A1C threshold was going to be with their input as well, and then started the process. And initially, a lot of our referrals were coming directly from the surgeons, but then over the subsequent years, our anesthesia colleagues have developed the PASS clinic, which kind of funnels everybody through the same system and offers more consistency throughout the whole periop process. And so now most of our referrals to the diabetes program are coming from the PASS clinic and are involving patients from many different surgical areas.
I know Kathryn brought up a recent paper that's been published, which looked a little bit at outcomes. Were you monitoring outcomes during those historical times, or is this something that it kind of became clear that there was an issue and kind of in a quality improvement sense kind of just evolved rapidly?
Yeah, that's another good question. We weren't necessarily, there were some retrospective studies that some of our surgeons did looking at, patients that have uncontrolled diabetes in the joint population. But when we started doing the POET program, we've been monitoring our outcomes with dashboards and looking what our A1Cs are, kind of looking at time to referral, how many clinic visits are they taking, what are their outcomes. But sometimes it's hard to, control for everything with just looking at the patients who went through the program versus people that didn't. So the study that Kathryn had mentioned was a controlled trial where we compared them to controls that were matched. And it was just looking at folks that were doing surgery that required hospitalization, so not ambulatory surgery. So it was a fairly small number, but even within that small number, I think we can see a fairly substantial glucose reduction, albeit not significant due to the N, but also some other things that are interesting, like what a lot of these patients have less need for skilled nursing facilities and things like that afterwards. And is that from the program, or is that from just a different patient population that we weren't able to control those particular factors for? That's unclear, but I think going forward, as we have more and more patients that are going through the program, we'll be able to expand on that kind of evaluation.
Excellent. And just looking at Slido here, one question that's come in, which kind of relates to that is are you monitoring long-term outcomes, and do the patients stick with the treatment in terms of the interventions that you have as an inpatient and maybe post-operatively, up to a year post-operatively?
Yeah, so we are monitoring long-term. And at this point, it does look like, just looking again at the A1C, so that's kind of the easiest thing for us to follow long-term. It does look like the A1C reduction is continuing on at a year and even at 2 years, up to about 1% or so. And so it does seem like there's long-term improvements. That said, we don't have controls to compare that. Maybe that happens to everybody that goes through surgery. So I think, we can't say for sure, but I think from our perspective, it looks very promising. Anecdotally in clinic, the providers that see the POET patients, feel that they're a very motivated group and find it very rewarding to work with them because of the changes that they see so quickly.
Excellent. I know in Kathryn's talk, she did allude to the limitations maybe of HbA1c, and while it's something certainly we in our institution use as a marker, interestingly, studies suggesting that certainly in the non-cardiac population that it maybe isn't that predictive of perioperative outcomes. Are we using the right measure to assess these patients and to maybe predict the patients who won't do well?
Yeah, I think of it more as a flag. When we looked at our data and we looked at A1C, looking at the outcomes versus 3-day periop glucose averages, looking at the outcomes. And when we controlled them for each other, because most of the studies that were out there didn't control A1C for glucose, periop glucoses, didn't control periop glucoses for the pre-op A1C. And so when we really controlled those, we did see that that A1C does a really good job of predicting who's going to be high. But when you control for each other, it was the periop glucose number that was more important in predicting mortality, at least. And so I think we look at it as, okay, this is a flag. This person has an A1C. They're going to be higher risk for coming in with hyperglycemia. And so we'll use that as kind of a red flag to intervene. But I think that if you had somebody who had an A1C that was 10 and then you got them on a regimen and their sugars for the last 2 weeks are well controlled, I don't know that, we have any data to say that you have to keep going until their A1C shows that good control. I think, my personal bias is probably that time period. If we can get it controlled, that's going to be the most critical, but we just don't have that data.
The time span seemed to be, if you're using A1C as your surrogate marker, it's certainly going to delay surgery. At this point, I might bring in Dr. Portugal Scanlan, calling in from Dublin. Padraig, do you want to just tell us a little bit about yourself and your background, and in particular, some of your experiences and future experiences with the diabetic patients?
So I'm a consultant anesthesiologist working in Dublin. I'm involved with the Irish Perioperative Medicine Society, so interested in all things periop care, I guess. And so for this session, I'm wearing another hat, my Moped hat. So the study that's running, which is a pan-European study. So Moped stands for the management and outcomes of perioperative care in European diabetic patients. And so to follow on from the discussion you were having there in terms of outcome for diabetic patients coming for surgery, the Moped study will hopefully answer some of those unknowns in terms of glycemic control, HbA1c levels, and address that huge variation even within Europe, but also kind of globally to sort of address some of those unanswered questions for diabetic patients coming for surgery.
Do we have any evidence to suggest how well we're managing these patients this side of the Atlantic?
Well, certainly even within Ireland, there's a variation between which hospital you go to. If you're diabetic and coming for surgery, you'll be told to take different medicines before and after surgery. That's the same across Europe. Certainly there seems to be a focus on the hemoglobin A1C, with a very big red flag coming up if you're between 53 and 69 millimoles per mole. So 69 millimoles per mole seems to be the stop, pause, let's reevaluate things. And just from Kathryn's talk, you can kind of see maybe that's not the best measure to be going by. And so hopefully Moped might address that. But certainly at the institution that I work, there's always an individualized patient approach. And so just because the hemoglobin A1C is above 7.5% or 69 millimoles per mole, it doesn't always mean that surgery gets stopped or cancelled.
In terms of the specific outcomes that you think are important here, or the variables that we need to concentrate on, is any like, I know you're really only beginning to recruit in Moped. What things are you looking at?
They're patient-centered outcomes, really. So the primary outcome for this particular study is days at home at 30 days. And then we're looking at some secondary outcomes. So length of hospital stay, dysglycemia perioperatively, mortality, a comprehensive complication index, and if the patients are in hospital for their first day, the quality of recovery score. But I guess the importance is to shift towards, patient-centered outcomes and trying to see what they are for each individual patient.
And finally, I'm going to introduce Dr. Niamh McAuliffe, who's been sitting quietly beside me for the last little while. Niamh, do you want to tell us a little bit about yourself?
So I'm Niamh McAuliffe. I work in Cork University Hospital and involved in the preoperative assessment perioperative program there. I want to take advantage of the experience available to me and ask a question. We talked about George and how we optimize him before coming to surgery. Peri-pandemic, that lead time is becoming more and more of a challenge with our preoperative assessment. And the patients who we don't get the HbA1c, we have identified that perioperative glycemia control is a very important factor. We brought this to our endocrinology team, and they were very keen on variable rate insulin infusions, and it's something that has a massive workload implication for the nursing staff perioperatively, which anaesthesiologists aren't very keen on infusion pumps that don't belong to them in the operating theatre. And I'm wondering if this is something you've had to deal with, and how you manage George when that time frame isn't there and you need to optimise his perioperative control.
So one of my main roles is the inpatient consult service at Duke, and we consult on about 90 to 100 patients a day is our census. So it's a pretty big census. And our anesthesiologists are pretty aggressive about starting IV insulin perioperatively. And we can do IV insulin therapy on pretty much any of the units in the hospital. We use it fairly frequently. We do if it's a shorter surgery or if it's an ambulatory surgery and the patient's not going to be staying afterwards. We do have some correction dose tables of shorter acting insulin that can be given sub-Q to help bring the sugar down. If it's a longer surgery, or if they're going to have dexamethasone and other things that might be driving the sugars up even further, we have a low threshold to start IV insulin.
I'm going to bring Saul back in because I know Saul has been instrumental as well in the development of the program at Duke, and I'm sure there's a lot to add to the development of this program. Saul.
Thank you. I guess what I'd like to add to this conversation are two comments and a question. And I'll begin by saying I really enjoyed, Tracy, your metaphor of a flag and how we should be using A1C to sort of trigger, if you will, our index of suspicion that something funky or bad is looming. I couldn't help but think of the tools we use in perioperative medicine to identify some of these chronic comorbid medical conditions. And I think there's a good analogy. So, for example, we use stop bang as a flag to entice us to go further and investigate whether or not somebody truly does have a diagnosis of sleep apnea. And what we heard from Paul Wishmeyer yesterday is we're now using this tool called PONS, or the Perioperative Nutrition Screen, as a very user-friendly flag to sort of entice us to go further and diagnose malnutrition syndromes. And I think in that context, the A1C is a flag to alert us to potential badness that could happen as a consequence of poor glucose control, and therefore entice us to really be much more aggressive to treat glucose as a precursor to those adverse sequelae in the acute care setting of surgery. And I think if we look at it in that context, it's much easier to put the two together in a meaningful way. And I do think it's the glucose control that drives many of those acute outcomes that we're trying to mitigate. The second comment is those acute outcomes that we're trying to mitigate for the studies that are, being designed. They're longitudinal outcomes that we have to be patient and tenacious to look at. And though we're beginning to see signals that we can impact a difference by bending the curve, we have to just be tenacious to continue to look for those sort of outcomes. The third comment that I want to raise, and I'm going to shut up and let you guys talk as much, is I think one of the best or most meaningful benefits of the perioperative diabetic program is really linked to population health. Many of these patients come to surgery and their touch point for being introduced to medical care is the fact that they have to confront the reality that they're having surgery. And so please speak to how many times we see patients who don't even know they're diabetic until they're evaluated in preoperative, clinics, and then are firstly introduced to the realities of what that means for them long term, not just in the acute care setting of preparation for surgery. And the things we do that stick, and again, the stickiness of the teachable moments that we have to sort of help their newly understood diabetic diagnosis. And the question I have is from Slido. One of our listeners asked, what can we do to sort of pass forward the training and the teaching and the management instructions that we give patients once we identify them as poor glucose control for perioperative purposes that they can carry with them even after they leave surgery?
Yeah, Kathryn, I suppose in the outpatient setting, you kind of see, particularly in the postoperative period. Do you want to take that question first?
Sure. No, I'm happy to. I think that's a really important question because it's not just about short-term outcomes. It's about how we manage them long-term and ensure optimization for many months and years after their surgery. So I think that this sort of highlights the importance of having an excellent team and having the appropriate multidisciplinary team. So it's not just providers, it's also nurse educators, it's potentially nurse navigators, it's your other staff, your diabetes educators that you really need to be able to help support the education of the patient. When patients are newly diagnosed with diabetes in the perioperative period, that's a really important time for education because they're very receptive, they're very interested, they're very engaged. And so Saul mentioned how frequently that happens, and we all know that. We've seen that in the hospital, particularly with our cardiac surgery patients. Just again highlights the importance of being able to build the team in your institution and knowing how you're going to pass patients off across the continuum, both perioperatively and then afterwards.
One of the other issues that Saul brought up there is, Tracy, you might be able to answer this. Do we have a good marker for severity of diabetes? I know diabetes is a spectrum disorder, but compared to, we'll say, COPD, can within a number of words explain where a patient is at. Does A1C do that? I suspect not, but I'd be interested to see your insight.
Yeah, well, we do have data just looking at patients with diabetes in general that if we're lowering their A1C, we're going to reduce their risk of microvascular complications, retinopathy, neuropathy, nephropathy, as well as macrovascular complications, though that data is a little bit less clear. But I think even in those folks, that are coming to the pre-op and they have a new diagnosis of diabetes and it's completely new to them, their A1C is 7%. They didn't even know that was an issue. I mean, it really is a window of opportunity to get them down a path where with lifestyle changes, they may be able to get rid of their diabetes and they might be able to just manage it with diet and exercise. And that is, I think, a really powerful motivator for some of these folks. But I think just talking about the complications and the A1C, we do know that in general, the higher the A1C, the higher the risks of the complications. And if we lower it, especially if we bring them down from double digits to single digits, we're going to see a lot less complication risk.
In terms of the new diagnoses through the pre-optimization program, do you have a sense of what proportion of patients that you're optimizing are new diagnoses?
I would guess, I don't know the number off the top of my head, but I would guess it's probably maybe less than 10%. I don't think it's a lot, but it's a few that we get, and then we can start them on usually metformin and some lifestyle changes, get them over to the diabetes educators and into the nutritionists for counseling. I
might return maybe to Niamh because devil's advocate. You've got limited resources. You're setting up a new program. Your decision is to concentrate on inpatient management versus pre-optimization. Based on Kathryn's talk and some of what we've been discussing here, is it just about getting the perioperative sugars right? Do we just concentrate on that and forget about the pre-op? Don't delay surgery. Just get them in and get on top of the sugars. Is that the answer?
No, I think Kathryn's highlighted really nicely. Just because you can't get at them at preoperative assessment, which is incredibly difficult, and I join Owen being jealous of the system that you have in Duke and the resources you have available. The teachable moments continue throughout the perioperative period, and there have been resources rolled out in a project in the UK looking at perioperative diabetic packages with breakdowns of how to manage people's sugars being shared with the patient and manage their medication shared with the patient. And I think allowing patients to participate in their perioperative diabetic care and communicate to them is really, really important to achieve what Saul was talking about. So even if they aren't preoperative assessed, if they come in and are involved in their perioperative sugar management, discussions are had with them, if they're informed what medications are being held and how their sugars are going, there's still a teachable moment in that inpatient admission, which shouldn't be lost on discharge, and certainly would move, in a resource deplete environment towards educating them for their post-discharge period. And I certainly wouldn't, for lack of the ability to preoperative assess patients, throw that opportunity out. And I think involving patients in that own perioperative course is very important. And you see it most clearly in the type 1 diabetics who come in on the insulin pumps. They are usually very, very knowledgeable, very involved. And they are very nervous about losing that autonomy when they come into hospital because they know their diabetes best. And I think the most important thing we can do as medical practitioners is listen to them, be involved with them and have a dialogue with them throughout their entire stay. That'll be something I think we can do when the resources aren't available.
How do we, those who are referred in and not necessarily a part of due care, how do we manage the process to ensure that they are transferred back to their primary care physicians with instructions and knowledge of how they should care for the diabetes that we so diligently manage in anticipation of their surgery? What's our transition of care process?
So we don't have anything specifically outlined. That's up to each individual provider as far as transition back. But from my experience, this is someone that normally should benefit from an endocrinologist, then they will stay in my clinic. If we're able to optimize them and they have excellent glucoses post-operatively, their medications are lined up, they understand the process, they understand the care plan, then at that point, I will transition them back to primary care if that is the mutually decided upon decision with the patient. So it's very individualized based on what their A1C levels have been, and if we can optimize all their cardiovascular risk reduction properties, blood pressure, cholesterol, all of that. So once that has all been evaluated and optimized at that point, then they can go back. Many of them that I have seen don't necessarily need to be seen by an endocrinologist. They just need more rapid glucose reduction for surgery. They need potentially a new medication moving forward. And then once that's taken care of, then they can go back to their primary care doctor. So that's been my experience. Tracy, I don't know if you want to add to that.
I agree. If they do go back, a lot of the providers can see our notes in Epic, or we'll CC the chart to them. And we can also easily send letters with just the click of a couple buttons in Epic. So it's pretty easy to get the information back to the referring provider or to the primary provider.
A sort of related issue, given the context of maybe some of the talks yesterday where, some of the other elements that we optimize, one of the issues that's very topical is the optimization of anemia. There are algorithms slightly different in different institutions whereby iron or maybe EPO is administered within an anesthetic clinic and based on algorithms. Now, I would feel a lot less comfortable administering, we'll say, certainly it's commencing insulin as an anaesthetist without backup. But one of the questions from Slido is for community facilities, what do you think about working with a community endocrinologist to develop an algorithm addressing blood glucose and A1C rather than sending the patient out to maybe or into you and Duke, that maybe those patients could be managed in other facilities with a bit of guidance just based on an algorithm. What do you think of that, Tracy?
I think that would have a lot of potential to work and could reach a lot of extra patients as well. As long as there were providers that were at the institution that were also interested in doing it, could be one of the barriers, I would presume, just because everybody seems like they're, especially in the primary care world, everybody's just really busy.
Certainly in my institution, where I have very limited access to endocrinology, often the most practical point if I see a patient coming through pre-op assessment is to refer them back to their family physician, who I know can look after them in an expedited fashion and also will need to follow them up. But I know that they're overworked as well. So, this brings back to, the absolute jealousy I have of the idea of seeing an endocrinology service within
I think
days.
Another potential idea, especially if there's not a lot of providers that are able to see diabetes, would be to train a nurse practitioner or a physician's assistant in diabetes management and even keep them in the anesthesia realm so that they're there as a resource and they can do some of this while they're seeing the patient pre-op or have, it's kind of stationed in there for questions from other anesthesia providers.
We need to promote the idea of having almost freestanding clinics that are staffed by advanced nurses for this very prevalent problem, one that is just sort of overwhelming the access of, our traditional models of delivering care. So it's sort of a disruptive idea, but I'm going to ask you to speak to that.
I will just highlight that the advanced practice providers at Duke have really been key to the success because we need all hands on deck to be able to see patients and to have the slots for access. And so physicians and assistants and nurse practitioners in the U.S., are providers that have a master's degree. They're trained in assessment and diagnosis. There are actually really great studies about the care that they provide for diabetes management. And so this is an excellent opportunity. If you're sitting there thinking, how do I resource this? That's a perfect opportunity to try to bring those providers into the fold to see the patients both pre and post-op.
Sol, I might follow up. You were involved in some of the resourcing of this service in the first instance. And once the need was identified, How did you go about bringing on the service? Or were the requirements not that high really and the willingness was there?
Yes. There definitely was great appetite. And I think Tracy spoke to this initially in terms of the triggers and sort of impetus for us to start the program. It was really through the lens of many of our surgical colleagues that were asking for help and our response to that. And that's how we stood up this particular POET program, initially through our response to our orthopedic surgery services, and then it just expanded to all surgical services. It was not a heavy lift at all. I met Tracy, goodness gracious, Tracy, years ago. I'm not even certain I recall how, but there was immediate receptiveness to the idea. And through Tracy, I was able to grow this program for POET. And I'm sure you had equal receptiveness within your division and amongst your colleagues to go forward with this. There was a capacity to manage the initial expectations, which were small and grew steadily. And over the years, I think, we just figured out how to connect those dots. And fortunately, we had colleagues that were very willing to help grow the program. So I think, to your point, the first thing is that there was willingness institutionally to do this. There was a great desire and appetite institutionally to do this. People bought into the idea. There's a reality and there's a business of healthcare. What we've begun to do is figure out how to manage the costs of staffing and scheduling and ensuring adequate access. And there are ways to bill for that, even in a fee-for-service world, however limiting they are. And it's a clinic visit like any other clinic visit. It's just a question of prioritizing this clinic visit relative to the urgencies of surgery as opposed to, non-surgical care medicine. And that's pretty much how we're sort of putting it together. Tracy, I'll let you speak.
I agree with what you said. You summarized it all very nicely.
Padraig, I might go to you. I think, I suspect you do not have a service like this. I know you've spent some time in the NHS as well. There might be a great desire here, and certainly theoretically, and maybe there is a little bit of evidence out there suggests that maybe there's huge cost savings here. If you go into work, tomorrow, having heard this talk and said, right, we need to set up this service, do you think the appetite is there to change?
Definitely. And I have to say, I share the same sentiments that you've already said in terms of the amount of jealousy that I have over this perioperative enhancement service. For sure, I think the enthusiasm and the engagement is there locally. There's definitely space for evolving this kind of integrated service. Clearly a cost-saving benefit to it if patients stay longer, have less complications and go home sooner and feel better. It's just the difficulty of breaking down those barriers of traditional medicine and healthcare. But I think it would be easy to engage your local endocrinology service, but following that service through there's barriers for sure, but nationally within Ireland, I'm not sure if there is a service similar to what Duke has, but each institution across Ireland for sure would have an enthusiasm to develop it.
Niamh, I might follow up with the same question for you as well. And next step will be we'll go national. We'll get the Department of Health involved.
I think so, because as you've shown, there's if you bring it down to numbers, to take the clinical side out of it, there's a cost benefit, which is the bottom line in many healthcare services and healthcare industries, and there's a proven cost benefit. So I think you're pushing against an open door in terms of using the opportunity of an inpatient admission to have long-term benefits, both as inpatient care and post-operatively. So I think it's something that is going to be very popular and will be driven forward. There's two
relevant documents in terms of UK-based research at least one is a research paper and one is a guideline. NCPOD produced a document in December 18 or 19, I think at this stage it's 18, called Highs and Lows, which is basically looking at the experience of the perioperative management of diabetic patients in the UK. And certainly, in my mind, it reflects poor management is widespread. Following on from that, the newly developed Centre for Perioperative Care, the CPOC, has produced a guideline just earlier this year. And I know Mike Grucott is heavily involved in CPOC. And it certainly has given the impetus for change in the UK. I'd be interested to know, will that change come soon? It would be remiss of me not to mention those two documents. One thing in looking at the documents, comparing the Duke experience with what's in the guideline from the UK, is that guidelines seem to be concentrated probably less tight control of sugar, certainly at the low ends, not going to the 80s, recommending certainly in the immediate perioperative period 6 millimoles per litre or 100, and also being a little bit liberal on that first post-operative day, allowing blood sugars to rise to 200 or 12. Is the risk of hypoglycemia, in particular seeing as we know that prescription errors do occur, and insulin is a dangerous drug. And maybe I might go back to Tracy as the endocrinologist. Can you understand why there might be a slightly different take at a national guidance where you're looking at institutions that maybe aren't as well resourced as Duke?
For us, inpatient-wise, the ADA recommends Periop 80 to 180 as the glucoses. That said, I think most of us, when we're managing the patients in that acute setting, knowing that they might not eat as well, we're really trying to avoid hypoglycemia. So if we see that patients are consistently running less than 100 in the hospital, we start empirically backing down, realistically aiming more for the, low to mid 100 range, 120 to 180 kind of oftentimes, even though our guidelines say 80 to 180.
80 to 180 is a nice sort of range, but with respect to it being consistent or inconsistent with a guideline and what the true value of those guidelines are, I think we have to not lose sight of the forest through the trees. Again, our program is predicated on the idea that we have this sort of trigger, and our trigger is an A1C, indicating that there has been chronic mismanagement of sugars over a long period of time, and that patient, by the basis of that trigger, is more likely than not for risk of adverse surgical outcome. So that's sort of our flag, again, to use Tracy's metaphor, to bring this patient into our clinic to be more attentive and have higher fidelity of management. And I don't think we should get so hung up on whether or not our guideline is aligned with another guideline, but rather that we're identifying patients who we believe are high risk that heretofore would not otherwise have been identified. And then we're doing stuff. We're doing something to make them more likely than not have, blood glucose control to mitigate those downstream adverse events that are commonly associated with people with poor blood glucose control during the surgical period. And so, let's keep that in perspective and not get too focused and hung up on a guideline of a number that is a basement or a ceiling. And I think that's the real value of this program, is that we're just sort of picking these people out of the pool that we think are more risk than not for adverse events because their glucoses are poorly controlled. And I think that's the true value and message here of the perioperative diabetic program.
Kathryn, I know you have some use of short-term perioperative glucose monitoring at home in select patients, which is something, again, I would love to have access to, but I don't. And, a rapid rate of revolution of the management of these patients, and both in terms of those requiring insulin and also monitoring. With the advent of COVID recently, some experience of telemedicine, is there maybe a role for, telemonitoring of these patients? And does that technology exist? Would that be of benefit to you, that you might be able to leave them wear the monitor and just kind of like ECG telemetry, as soon as they get to the point, they just get the green mark?
Of course, continuous glucose monitors are becoming more and more popular. They're also becoming more accessible with better coverage in the United States. And for example, most patients would not pay more than $75 per month for the Freestyle Libre 2. So we use them as much as possible for select patients. And I think that perioperative patients are the perfect patients to use them for, because we really want to see those short-term outcomes quickly. So I will use them whenever possible if the patient is able to afford them and we're able to get them. And so there is this push for this sort of glucose telemetry, being able to monitor patients from a distance, which we are able to do if they use the device in a certain way. So for example, with their smartphone, where it will upload the glucoses to the cloud. And that's an excellent way to be able to monitor them on a frequent basis. And so that also helps with telemedicine visits. So if I see a patient in clinic in person for the first time for their perioperative appointment, and I make significant changes to their medication, then I can schedule them for a telemedicine visit, let's say 2 weeks later, and be able to see the changes that have occurred in that time period. And that really allows us to optimize them quickly and to evaluate the results much more quickly. So it's been a beautiful tool for us to use for many patients, but for this group in particular, because we can really see the effects quickly.
And Tracy, you probably have a little bit of insight into where some of the technology is going a little bit better than the anesthesiology group. Is there any revolutions that will be coming our way over the next few years that will maybe make the perioperative visit, different? I know there's some recommendations on the use of insulin pumps around, diathermy machines, which we can usually get around, but is there anything else coming down the track?
Yeah, the technology is changing quickly, and a couple of things that have come up at our institution that we're trying to develop, ways to consistently address. Patients now are starting to what's called do-it-yourself looping, where they're buying these links online, and then they can set up basically their pump to go back with their phone and do like a feedback and like a closed loop, and they're kind of making it themselves, and it's actually working really well for some of our patients. But then how do you handle that when you're in the OR? And so I think, some of the technology is really great, but some I think is also challenging in the OR, because if it is a patient who's on a pump that requires, reading from their CGM, and the CGM is taken off or doesn't work, there's some potential downfalls as well with some of the new technology. I think, kind of our overarching guideline for anesthesia right now for if patients do have pumps is, if it's a patient that's going to be in the hospital, they're already in the hospital and having surgery, or they're going to be hospitalized after surgery, we actually then use IV insulin during the surgery and then have the endocrine team help the patient to get back on the pump after surgery. If it's a shorter surgery, an ambulatory surgery, and they're not having radiology exposures that are going to damage their pump, then we leave those on just with the basal rates. But I think that, this is going to be an ever-changing field just because of the advancements with the closed looping particularly. And that's going to be something that we'll have to continually address.
Might go back to Slider. I know this is the question. If you've got a HbA1c over 8.5 or 69 millimoles per litre, should you postpone surgery for 3 months? What do you think, Niamh?
So it's such a broad question. I'm going to say, based on everything we've said, is no. You really have to look at individually and what kind of surgery they're having. But we've been talking about HbA1c as a marker, but also the perioperative glucose control is important in defining. So I don't think you can blanket say a HbA1c 8.5 is just an automatically cut off for 3 months, because there's too much behind and before that. And, he could have been coming from 10.5. This might be a good HbA1c for this patient. So I would say no, I don't think you could take that as a blanket statement. And certainly if we applied that in our preoperative assessment clinic at the moment, then no one would be having any operations, because our lead times and our urgency of surgery has become the biggest challenge in trying to implement this perioperative care program, which we know should happen.
Padraig, I might ask maybe a slightly different question. In your institution, if someone has a HbA1c of 8.5, what's the likelihood that they will have surgery in 3 months, or are the mechanisms to deal with that at such a rate that probably will be 3 months before they get their surgery scheduled for something very elective, not time sensitive?
Well, I guess it forms part of the whole shared decision-making process. And as Niamh said, doing an individual risk assessment for that patient. So broadly speaking, no, they wouldn't be delayed for 3 months. But for sure, you'd link in with your endocrinology services. And certainly at the institution that I work at, there's no dedicated pathway, but for sure you'd have a dialogue early to try and get this surgery done. And there's definitely not an impetus to cancel or to defer too much, because a lot of that work would not get done. But it comes to the center of, shared decision making and deciding on that risk for that patient in front of you. So to answer your question, no, it wouldn't delay, but for sure you do your best to optimize as quickly as possible.
Can I invite you to invite Feyce into the discussion to answer that question as well?
Excellent. Welcome. Maybe for the viewers, do you want to introduce yourself again? And I know you've participated already in the program.
Yes, absolutely. Thank you. So I'm Feyce Peralta. I'm actually an anesthesiologist here in Chicago. I work at Northwestern University. And I've been delighted with this talk, really kind of taking mental notes on how we can improve our practice and implement a program similar like like yours. One of the questions that I have, in terms of success rate, would you recommend a stage approach or a system-wide initiation? And the reason why I'm asking is because when we rolled out our enhanced recovery program a couple of years ago, we started up with 1 or 2 lines of services, surgical services, but something like this that is truly relevant to all of the different specialties, surgical specialties. I'm curious to get your perspective if you think that stage approach would be ideal for this, or you should just go on and recommend something like this for all services at once.
Happy to weigh in on that. I would recommend a staged approach just because, I think that it helps you to handle the volumes when they come and helps to kind of work out the bugs before it's gone live to everybody. I think if everybody's involved and things aren't going well, then people are going to be upset and they're going to just say this doesn't work and not use it. And so I think a stage approach gives you more control over the whole process.
So when you guys rolled this out, where did you start? How many services? Was there a particular line of surgery that was more receptive to it?
Yeah, we started with spine surgery and ortho, and then added ortho after that. And we felt that those were the ones that already had a fairly long lead time before surgery. And so it was less disruptive. And also I want to go off on the points about if a patient has an urgent surgery, we're not canceling or postponing surgery for colon cancer or something like that. We're going to do what we can in whatever time frame we have to get the sugars controlled. But the patients that have the more elective surgeries, like, they're getting a new knee, that gives us a little bit more time to kind of really feel like we're doing all that we can. I would definitely do a staged approach.
Can I ask, just in terms of practically from your experience, how long did that phase last before you were able to work through the bits that you needed to work through and scale up? And then did you go from relatively small to full blown?
We probably grew from spine to ortho over maybe the course of a year. And I think along, much of the process, Saul and I would talk about, the floodgates are going to open. Endocrine's going to be overwhelmed. And it never happened. It just kind of slowly built up. It hasn't felt like an overwhelming process during this. But I think that the stage approach helped. And I think, now that it's through the PASS clinic, it's kind of getting just a more consistent referral from month to month standpoint.
We definitely would argue that stage is better for no other reason, just to ensure that you have downstream capacity to handle the load. Our surprise was that when we thought we would open the door wider and have to scramble to meet the demands were not there. And so coupled with the staged approach proactively was a lot of road shows. I would give grand rounds. I would, get myself in front of each division and do a little dog and pony dance. And it's been a constant marketing campaign as much as it's been, a downstream process of accommodation. Culture is hard to change. And so I think everything we're talking about is very cool and sexy and proactive and neat, but we should not lose sight of the fact that tradition is a huge barrier to change. And so you have to have champions, and you have to be willing to, climb a mountain and shout.
We're running out of time here, but Feyce just come in, and I know, Feyce, can I ask, is your experience in Chicago similar to maybe what was the case in Duke a few years ago, and that it kind of was case by case, or do you already have a preoperative diabetic element to your preoperative assessment?
Unfortunately, we don't. We don't have a robust system as they do at Duke. So hopefully we can reach out to Kathryn and Tracy and get more information on how to keep moving an initiative like this forward.
Excellent. Yeah, I think there's. I would suspect most of our viewers out there are really jealous of this program. And again, I know there'll be certainly amongst colleagues here in Dingle and elsewhere, there'll be discussions about how to maybe collaborate to get this pushed through, because we have a slightly different funding model on our side of the pond. But thank you so much to Kathryn, Tracy, and Saul from Duke, and Feyce. I know we've only got you involved late in the discussion. Thanks also to Padraig in Dublin, and I hope to see you soon. And thanks to Niamh here. Saul, I don't know whether you have anything else you want to add before we close this.
I just want to, bring Feyce in as the co-host of EBPOM Chicago. She, has been working with me behind the scenes for the last 6 months to put this program together. And with that said, I'm going to invite her to close this session and invite everybody to understand what's on deck for the rest of the afternoon. Feyce?
Yeah, so I'm really looking forward to those sessions.
Top Med Talk.
The Society of Cardiovascular Anaesthesiologists' 44th annual meeting is coming soon, and Top Med Talk will be there. If you want to pop along and see us, it's on May the 14th to the 17th in Palm Springs, California. Check out scahq.org now for special offers and more details. Also, if you're not sure if you can make it in person, why not explore the virtual track? Innovation during COVID-19 now means more than 60% of this year's sessions will also be fully available for you online. Check out scahq.org. That's scahq.org.